Hi, good afternoon. I've stepped in at the last minute for my colleague Barbara. I'm a research nurse and we do research on neck of femur patients with dementia and how to enhance their recovery. And as part of that, we look a lot at prevention of delirium, which Barbara works with. So just bear with me today because this is a presentation and she said just talk through it as you want. So we'll see how that goes. So POD is an intergenerational project and it's a care approach to support people at risk of developing delirium in hospital. So to tell you a bit about Calderdale and Huddersfield, we're two district hospitals and in Calderdale we own some of our community services. We're a similar size to Bradford and we've got a similar problem of a growing population of older people. And we've also got a growing number of people admitted with hospital with delirium or developing delirium. Through my research, it's certainly highlighted that we have about a quarter of our hospital beds. And on our orthopaedic wards, our neck of femur wards, sometimes we can have 15 out of 22 of our patients with some cognitive impairment. We also see that there's problems recognising the risks. And there's definitely issues around diagnosing it and treating it. There's a lot of nervousness around saying someone has delirium and putting that label on them. The NHS is under pressure. I'm a ward nurse as well, 1 day a week, and I know what it's like to face those complex demands. And we all know that delirium can potentially be prevented or reversed. So this is Barbara's audit on how it was. And I'm at quite a unique place where I'm the person who was in how it was. So we did have a lot of falls. We had a lot of incidents. We had a lot of people going over the bed rails, fighting with the bed rails. We had a lot of people who were agitated, wondering. And as a nurse on that ward, as I'm trying to tell these people to sit down or don't go up there and watching those patients, there were the other patients on the side who were sat and they were isolated and they were bored. And we had quite a few patients that we discharged to care homes because these cognitive difficulties hadn't been properly managed. So staff, this is me, we had low morale. You would go to work and you would love to spend time sitting with these patients, but you would have a doctor's round, you would have a medicines round, you would have drips bleeping at you, and you would have high levels of stress trying to control these environments. And because of this, we had a lot of sickness, we had a lot of absence. We had a lot of trouble actually recruiting staff into our ward, and once we had got staff, keeping them on our ward. We had quite a few complaints that people weren't getting the adequate support that they could have had, and the care was generally uncoordinated. So this is just an acknowledgement of the research that brought out our POD system, and this was to test the feasibility and acceptability of a multi-component system of care to prevent delirium in older people. This was done by the University of Leeds and some other researchers from Bradford, and it was modelled on the Hospital Elder Life programme, which is an American study which is about volunteers being involved in preventing delirium. It were a 3-part study, and we were involved in the design and we were involved in the testing, and they're in the process of evaluating how that's been. So this is our POD. We are aimed at people who are 65 or older with cognitive impairment or dementia, hip fracture or severe illness. I remember in 2012 when this came out and 2013 when it hit our ward, I said to Barbara, this ain't really a lot of our patients because severe illness is ICU and things like that. And she defined it as anyone who is admitted and not improving up to 72 hours. So that quickly became the majority of our patients, hip fracture, cognitive impairment, or someone who was quite unwell. And on the side, those are our 10 clinical factors that we use to help reduce delirium. So the prevention and management strategies that we used, they came together and they made us a managing tool, a care tool for the nurses, for the medical teams and for the therapy teams to use. It was based on the 10 components and gave us advice on each of those pieces. And that really changed the ethos of how we was on the ward. We understood what delirium was about, that it was okay to look for signs of delirium. They then went on to look at specific interventions. And do those interventions necessarily need someone who is a nurse or a doctor? And they found that we could have help of volunteers and they would be able to manage this prevention of delirium as well. We have volunteers from colleges now, but when it first started, we really struggled. The volunteers came in, they came for a couple of weeks and they left. It was difficult to manage the kind of volunteers we were getting in. The third part was meaningful occupation, again about stimulating through good engagement, something that as a nurse on the ward you wanted to do but you just didn't have the time to do. So Barbara will absolutely shout about 2 volunteers that we had called Hannah and Jacob, and they came from separate colleges and they helped us build a case about an enrichment placement, and it was about getting students in from college who would want to go into the medical profession, be doctors, be nurses, and now we could support them. So now we started with a few volunteers to 40 volunteers to this year we've got 68 volunteers coming in, and we get those volunteers in by having interviews with them. We ask for references from them. So the kind of students we get are really committed, enthusiastic and have real purpose to what they do. We've got one volunteer on the ward at the minute and she said to me, oh, it's my holiday next week. And I said, oh, that's fine, don't worry, you don't have to come in. And she's like, no, I want to come in the other 2 days. And it just shows the difference in the kind of people that we've got, and they really are engaged. Now, they need training and they need mentorship, and we need to be evaluating what they do, which is great, except our dementia lead works 3 days a week, and that just isn't enough to support 60 odd people. So she's put a business case forward and we're going to get a band 4 and a band 6 to help support these students. And just to give you an idea of actually what they do, they don't look at medication and they don't look at bowels. But we have one girl, Bethany, and she was sat talking to a lady and she wouldn't get out of bed, which is a really big thing for an orthopaedic ward. We can't mobilise her. And she found out that it was because she didn't like our slipper socks. She didn't appreciate that they had grips on the bottom and that they would keep her comfortable. So she thought she was going to fall. So Bethany went and she used our, what we call my hospital diary, communicated with the family and got her own slippers brought in. And yes, it was tight on the leg that she had had the surgery on, but she would get up and she walked and she actually engaged with the staff. These volunteers, although they only come in for a couple of hours, can make a massive difference to the care that we give. And from the volunteers, we've now got, like I say, 68 of them, and they come in and they provide companionship for our patients. They use the My Life units, although I'm not supposed to call them that, am I? And because they are between 16 and 18, they are fantastic with them. They come in and they can put all these things on, and they really look at these patients and have the time to talk to them and find out what they like. They can search on YouTube, and one day I came in and in bed 12 I'm like, what on earth is that? And the 2 volunteers were doing karaoke with a lady. Well, I didn't know we could do karaoke on these machines. And this woman was sat up in bed, singing and really enjoying herself in hospital. So these students will basically do whatever the patient wants. And it's not just what they want, they will learn about that person's identity and make them feel important in hospital. So the students were such a success that we got funding for what we call social engagement and support workers. We've got a superwoman because they are all women at the minute, but we'll see. And they again engage in reminiscence, life story work. They work with the My Life units, and we're in the process of developing a patient and carer journal, and it's a hospital diary, and it's something that the family can write in and the social engagement workers can write in, and on that we say, can you let us know any complaints, any concerns, and we can sort of nip those in the bud quite quickly. We have one lady and she would not get out of bed, which isn't unusual. And from Debbie, our fantastic engagement support worker, talking to her, we found out that her view of hospital was to be in bed. When she was in hospital, whenever she saw people, they were in bed, and that's how she thought she had to be. So once it unfolded, we got to say to Ruby every day, oh, can we just clean your bed? And she'd get up because she appreciated that hospitals need to be cleaned, so we'll get out of bed. And she eventually worked her up to, we need to clean your bed space. Do you want to come and sit in the day room? And this lady who was isolated, who was bored, will now come up to the day room every day, and she'll sing songs with us and she'll engage with us. And that's made a massive difference in her care. So generally our care philosophy is recognising the risk. So it has just changed the ethos on the ward. We all know about the risks. We all know how difficult it is when someone can't walk, someone can't see, and we're not afraid of asking that question every day, is this person more confused? So we're highlighting it early so we can get on top of it. And we're encouraging the engagement with families and carers. We've signed up to the John's campaign, and we are really working with families and encouraging them to come in and bring the day clothes so there isn't people just sat in the nighties. And we're understanding that person. We are making activities and memory care plans about them, so they are engaged in what we do. And again, that's reflected in the person-centred care planning. We know that if a person will get up with the right slippers and they will get dressed, they are more likely to make a better recovery. We use the My Life, which we've talked a lot about. And social engagement, our engagement support workers, every Tuesday have got the hairdresser to come in, and we have a salon every Tuesday. And it's absolutely brilliant because we have the music playing in the background, and they all have a cup of tea and a piece of cake, and they all have the haircut. And all the patients we have really enjoy coming to our Tuesday salon. And then on a Sunday, we tried to get our vicar up, but obviously on a Sunday it's a busy day. But one of our students got a YouTube up, and now we can sing every Sunday, and people will come out of the day room and they'll come and they'll talk to other people. And reorientation, obviously these students are just brilliant at getting to know the person and making them feel their identity. They have their own belongings, they have their own slippers. One lady, to aim to get her back home, a student laminated the picture of her house that her daughter brought in so she could see what she was aiming for, and that made a really big difference to her care. And then obviously reminiscing. We had a Remembrance Day, and it was really a hard day because one of our patients who didn't normally engage with us, didn't normally speak to us, came and he was watching the Queen's speech and he burst into tears. And from then on, we've been able to talk to him about the war, and he started coming out of himself, and it's made us learn about who he is. And then we do the My Story work, and we look at people's lives. And another example is we've got a gentleman with Parkinson's, and he has to take his tablets on time. And the engagement support workers, they managed to get it so that on one of the systems, they got a video of his wife saying, it's time to take your tablets now. And he would just take them. And as a staff nurse on the ward, something that would take me an hour to convince this man to take his tablets would now take 2 minutes. So they're just brilliant. So just a quick acknowledgement of the butterfly scheme and how important that is. We don't have the forget-me-not, we have butterflies. So blue is for diagnosed dementia, and then white is for those with cognitive impairment and delirium. And those just let everyone know that these people might need a little bit more support. It's not about labelling them as that, but it's so that when people are coming to take the dinner order, they know that this person might need a little bit more prompts. Oh, I hate this bit, but everyone loves figures. The NHS is all about how we've saved money. So you can see that we had a lot of one-to-ones, and we did, because we didn't know how to manage the patients. So we'd book an agency nurse who'd come, and she would sit next to this patient and flick through the magazine. It didn't stop that patient shouting or screaming or trying to get out of bed. But since we've had the volunteers and the engagement support workers, they'll take them for the day and they'll really engage with them, and that helps their daytime, nighttime cycle. So we've got so many less one-to-ones. We did have a bit of a peak in April, but that was when our volunteers were studying for exams and our engagement support workers both had a week off, which was awful. And then this is just some of our falls. So before we introduced these roles, we had quite a few of the red falls at the bottom, and those are the serious harm falls. Those are the fractures or death falls. And then if you look at 2014, 2015, we don't have any red falls. We do have more green falls, but I think, as reflected earlier, you can have one person who falls a lot. And we did report all falls then. And then looking into this year, we've even got a further reduction in that, which just goes to show how important these people are in our trust. Don't ask me any questions.
Just a question about the volunteers. Just how do you just go to schools to recruit them, or do they come to you, or do you just advertise for the volunteers from the schools?
Barbara went into the colleges and put together, like I said, the enrichment programme, so that our trust could be part of their sort of role, really.
It's a good thing, isn't it?
Yeah, it's brilliant.
Thank you.